Thank you, Prof, for also joining. Hi, everyone. Thank you so much for our very first episode of Substance Talk with Shaun. We'll be having this twice each month, bi-weekly, and this will be an opportunity for us to engage and share with each other's challenges and also learn from one another. So this is our first episode, which will be getting an opportunity to explore and be a bit intrusive in people's personal views and minds between Shaun and Prof. Jannie Hugo. They will get to share their personal experiences and most importantly, the question, the why. Why even be interested in substance use related matters? What pushes them and challenges them to keep continuing in this field? So please be engaged. If you have any specific questions as we are sorting out the technical issue of the chat box, feel free to WhatsApp with this. And also continuously pose questions on the teams itself around any challenges you experience on the field. So Shaun and Prof, over to you.
So thanks, Dee. I think you've got a career in broadcasting after this, so that's great. Prof, thanks for joining us in this first session. And yeah, we hope that these sessions will assist people going forward. I've invited a number of international and local experts to participate, and we'll be doing so in the future. And thanks to Dee for the technical support and all the other support she's been given. Prof, I think let's start by basically asking a question of as Dee said, why we got here and how we got here. I don't know if you would like to just maybe fill us in with the background of yours, in particular with community-oriented primary care as a model.
Good afternoon, everybody. Can I just check? Can you hear me? I've joined on the phone.
Yes, we can hear you, Prof.
Okay, thank you very much. Yeah, as you know, we've been working in communities since about 2006. And as we started getting to know communities, especially in the inner city of Pretoria, but also in townships, including Mamelodi, we realized that substance use is a significant problem and it needs a response. We also realized that the institution-based responses that were available did not produce the necessary outcomes. And we were very challenged to know what to do. But whatever we thought, we knew that it had to be a community-based solution because that was the way we have worked. And I don't know still where we got all the information, but I mean, it was linked to a meeting I had with Shaun and a joint meeting we had in Johannesburg where I presented the story of the soccer game, and I can still remember the example that I used, because even then we realized that the criminal justice system involvement in substance use response wasn't necessarily helpful. And I still remember the meeting where I made the statement to say that you have the police playing in your team, but then sometimes you find out that they're actually playing in the other team, and that it's not. And then I said, if you are a coach and you see that, you will usually take that person out of the game and put somebody else there. And I think that's when I made the statement that that Nyaope should be legalized, which was nearly 8 years ago. It was, I think, August 2014. And in response to that, then we started engaging with Shaun and other experts and started working out a community-based program. Thanks, Shaun.
Thanks, Prof. Yes, so I remember well in August of 2015, that meeting, and when you came out and said legalize Niobe, and there was a huge outcry. It made the headlines of just about every single paper. And what was interesting for me was before I'd been considered kind of the radical voice in saying decriminalize drug use. And now suddenly I was being approached by the SABC and others as a more rational voice of maybe looking at alternatives to criminalization. But here was this professor who was well respected saying legalize Niobe, which created a gap to actually bring some of the narratives into the alternative narratives into a very prohibitionist setting where we were reliant only on the criminal justice system. So that was a very useful collaboration, although maybe not intended or not planned, but it's helped me plan certain advocacy efforts going forward. That you know, if you've got somebody credible presenting a radical view, it gives a space for somebody perhaps less credible to give a more moderated kind of view and get heard, which is good. So my background is not untypical for the field in that I was certainly had some problems with drugs in times of my life. I tell people I did an embedded ethnographic study into drug use and the underworld in Cape Town, which went on for about a decade, and that was after a business career, and ended up basically homeless for several reasons. But when I sort of turned things around a bit, I didn't want to go back into business. I felt that I could help people with drugs, as many people who've had a problem with drugs do. But I very quickly learned that personal experience does not qualify one for the field necessarily, and that academic requirements are necessary, and also that my experience was very untypical compared to the majority of South Africans. I'd never been arrested for drug use. I'd never been arrested for vagrancy or sleeping on the sidewalk or that kind of thing. Whereas the majority of my friends who didn't come from such privileged backgrounds as mine had been. And so I wanted to try, I came at it from an equity point of view that everybody needed some level of help, and started working in Lavender Hill in Cape Town, which is essentially a forensic group of people that we were working with. A lot of them were methamphetamine users, heroin in the form of unga, which is the same as Niobe, which is heroin. It was just making an emergence in the South African market, and I went and studied at the Department of Psychiatry at Stellenbosch University for a while. And while I was doing the work within Lavender Hill, working very closely with the community, I realized that an abstinence-based response wasn't working. It was causing quite a few problems, in fact, because people would never come back into services at all. And so I was looking for a way that I could promote more evidence-based approaches, and we were experimenting very much within the context of the centre we were running, which was South Africa's first non-abstinence based or non-abstinence focused centre for people who use drugs, and we were getting a lot of success. And that out of that program came several other programs which are still being worked with today. Anyway, I started working for TB HIV care in the harm reduction field, and I ended up at this conference or meeting with Prof. Hugo, and I heard about community-oriented primary care for the first time at that stage. And I remember standing in Prof. Hugo's office and him saying, yes, we organize the health system not alphabetically, but geographically. And suddenly this thing started coming together, and then we started discussing with Prof. Hugo's team the possibilities for COSUP, because the community-oriented primary care models seem to be a much better approach at a community level, rather than being very individually focused on individual people who are important, obviously, but also we needed to have services that people wanted to access. Prof, in those early days when we started discussing COSUP, I can't remember who came up with the name. I think it was one of the clinical associates, actually. We threw around quite a few names to try and fit it into the model of community-oriented primary care. But what, in your mind, was the potential in community-oriented primary care? Obviously, it is community, but did you see early potential in this, or what did you think the fit was?
Thanks, Shaun. I think if you look at the principles of COPC, the issue of equity, that's important. Realizing that in a society, people... Oh, now this thing is searching.
We can still hear you, Prof. Prof, you there?
I think maybe he can't hear us.
Hello, are you back?
Yes, we can hear you.
I was, yeah, my phone was searching. It found. So actually, the people who use substances are also exposed to many other diseases. So that made it clear that if you are serious about COPC, you have to give attention to people who use substances. Then the practice with science thing was that it was clear that what was offered to people didn't work. And then we learned more and opioid substitution, and that as a practice came up as a possibility. And then we just realized that you have to be accessible to be able to do that. And in our setup, you can't have people all traveling to one place to get access to care. And then the obvious way was then to take the COPC model and build a COSUP model around that, using community resources and building networks. But then obviously the challenge in Tshwane was clearly a heroin challenge, and then how you deliver a medically assisted program, or OST, which then challenged the whole COPC approach in terms of providing a clinical solution, making use of a Schedule 6 medicine in a community-based setting. So those were the challenges that we had, but we persisted with that.
Yeah, so exactly, from my perspective, one of the things that I was really seeing as a major advantage of the COPC approach was the fact that you had community health workers within the community who could do assessments of people before they developed a serious problem. So I suppose that would be the availability of a continuum of care. And I also saw the ability to deliver biomedical services into responses that were very unbiomedical at that stage. Obviously, when you look at substance use, well, for some people it might not be obvious, but for me it was obvious that you needed both the biomedical response and the social response as well, and COPC seemed to offer that. And with the emergence of heroin, we were very concerned in Cape Town about not having opioid substitution therapy, and I was very fortunate to do some time interning at the Stickland unit, where we were able to observe people who were being detoxed at that stage because there was no funding for maintenance, but some people were able to go on to maintenance therapy. And so that was something that had never been available in South Africa. And I think now COSUP is actually the largest single maintenance program in the country that's managed, and that's been a huge step in the right direction. And what really struck me was the geographical nature of COPC, that you could get all the information you needed about a particular community through the assessments. You could offer this continuum of services, and what I liked about the COPC approach was it was almost like having a drip into the community, you know, like being able to put anything that you needed into the community, because you had all the resources in the community, you had all the staff that were needed, you had the points that were needed, and so I think from my perspective, that was what was exciting, was this sort of to use a drug term, mainline into the community as such, that wasn't perpetuating this thing of stigmatizing people who use drugs and taking them and treating them as totally different and removing them from the community. You could now leave them in the community, because what I'd learned was that all the data said that formal rehab had very poor outcomes. That for me, the greatest mystery of all of this was, what was this thing that they referred to in every single paper about drug use called treatment as usual? Nobody could define that. And in South Africa, we had only one type of treatment available, which was generally a very confrontational and punitive approach on inpatient treatments. There were very few outpatient treatment centers, or I prefer not to call them treatment centers. In fact, I would call them support centers for people. And certainly there was no mixing of biomedical and psychosocial things. Prof, I think that COSUP has obviously developed out of those initial discussions, and with the team. Obviously, it wasn't just you and me. There was a huge team of people. I see Dr. Brewer is here as well, and many of the other people here have been involved in that team. For you, what do you think is unique about COSUP as we're seeing it in South Africa at the moment, or do you even think it's unique? And what do you think some of the wins have been with this kind of response?
I think what is unique is that there is a team approach that explicitly has a social worker and a clinical associate as a clinician, as core members of the team, as well as peers. We have community health workers as well, but I think those three elements are, I'm not sure if they are that unique, but the fact that we build it around that. I must just give you a bit of history. When we started designing COSUP, we had space for a full-time clinical associate and a full-time psychologist and a full-time social worker. We could not continue with the clinical psychologist as part of the team, partly because of people not being available that necessarily, and also budgetary constraints. So I just wanted to say that we had that as part of it, and I still think we will do well if we in future have more formal engagement of psychologists. What I also think is unique is how we work with clinical associates as clinicians under the supervision of the family physician. It meant that we could have quite intensive clinical care of people, and able to do comprehensive healthcare. Yeah, I think those are things that are. I mean, there are many things that we still have to do. I think the other thing that Shaun always mentioned is that we, rightly or wrongly, actually started off at quite considerable scale. So we used. I mean, I sometimes use the term a boutique program wouldn't be good enough. Now, I may have to moderate that in a sense, but the point is we decided not to go for a small program with a few good people around, but actually to do it at scale. And I think that's also unique at this point. Thanks, Shaun.
Thanks. Yeah, so for me, what I found particularly encouraging about the approach was that although you were integrating into a health system, you weren't fully integrating into the broken parts of the health system. You were adding to some parts of the health system that worked, and globally, we see how harm reduction has set the way and the benchmark for being able to reach previously highly marginalized populations and unreached populations. And so one of the things I often say to people is, you don't want to take a success story and put it into a broken health system, but you can bring the broken health system into the models and that which are reaching people, and broaden the scope and reach of those models into the entire community. So my initial excitement around the COPC approach and the development of COSUP was that we now had people in people's houses. We had people going there, not just for drug use issues. We had the possibility for delivering a continuum of care, and of course, offering opioid substitution therapy, and then also linking that with the HIV response, sexual and health and reproductive rights, and things like abscess and wound care, which was lacking tremendously. There was nothing like that. The other thing that I thought was very, which is still unique, and which is something I have taken to several conferences around the world, and actually sparked or contributed significantly to a paper developed by the Global Commission on Drug Policy, which is an organization that is made up of world leaders and former presidents and prime ministers. And they wrote a position paper on the role of municipalities in addressing drug use globally. And that's one of the things that for me has been exceptionally valuable. COSUP is still the only municipally funded harm reduction program on the continent of Africa. And that is absolutely unique. And also what's incredibly important about that is that is the only way that we will be able to go forward in the future with sustainable funding, is if we can mainstream the funding for drug-related services. So in order to mainstream it, it needs to be valuable to municipalities and to health systems. And up until now, any response to drugs or any interventions to help people resolve issues with drugs or to minimize the impact of drug use, those have been exclusionary, criminal justice based and prohibition based. And there is a danger in turning that into a totally biomedical response. It can be just as punitive as everything else. But what the COPC model and COSUP seems to have done is fit that gap in the middle. You know, it's reaching middle ground. So I see Dr. Bura here has actually asked a question about how do we get other parts of the country to catch up, and how do we bring about effect at a policy level. And what's been good is simultaneously to COSUP, there's been some experiments in Tshwane, and there's been constant engagement with the National Department of Social Development and the National Department of Health. We know about the challenges of expensive methadone, and now we're seeing in Tshwane an emerging methamphetamine market developing, and a lot of users of methamphetamine as well, which is going to be a new kind of challenge. But something like COSUP should be adaptable to meet all of these kinds of needs, which I think is also a kind of special point around the COSUP program. And so what I've got a lot of responses from globally is people asking me, how has this, how would you go about repeating this in a way that you make drug services valuable to municipalities and to the broader community? And I think what we've seen with COSUP is a lot of people have changed, and that change has been visible to the community as a whole. Maybe not as large scale as some people want, but I believe that it's been quite remarkable. And recently I was engaging with a group in Shoshanguve who have set up a feeding scheme independently. They are working as a network of people who use drugs together and are adding value to their community quite extensively. So I think that kind of thing needs to be almost marketed more. And although it's not perfect, I think the model has a lot of advantages that can be rolled out. And yes, Prof, I was not keen to roll it out at scale, but it happened at scale, and I think that there've been great advantages to that. And in Tshwane, it wasn't rolled out to scale, it was one site, and there've been some advantages to that as well. But the two of them together, I think is a very good advocacy tool, and something that I've been speaking to with Dutch government and Harm Reduction International and others about. Ubi's asking, is there still a place for traditional rehab centres? It depends what you mean by traditional. If you're talking about the no-ports of the world, then absolutely not. Those are nothing more than prison camps. People get better in spite of them, not because of them. It's the same as prison. But if you're talking about residential rehab, there is still some purpose around residential rehab, although it should sit at the end of the continuum of care. There's a First Nations saying in the United States, which is that if you take a fruit tree that isn't bearing fruit and you plant it in fertile soil and it starts bearing fruit, why, when you dig it up and put it back in the old soil, do you expect it still to bear fruit? Obviously, I'm not saying it as succinctly as they would, but that's the message in general. And certainly, when we remove people from the community, put them in an artificial environment, they stop using drugs, and then put them back into the community, unless you've resolved some of the other issues that drive drug use. Because remember, all drug use, even dependent drug use, serves a purpose in that person's life. We have evolved to prioritize short-term survival, and drug use is often a means of resolving that or meeting that need. So there is, particularly for people with dual diagnosis, I think there's value in it. And sometimes people just need a break out of their community, and there's some value there. But I don't think that should be the beginning and end of treatment as such. And I prefer to think of people as resolving their drug use issues. I don't think it's up to just one doctor to treat them or a psychiatrist to treat them. I think that treatment of aspects of what they're going through is very important. But overall, they need support and in order to resolve it. And I think that's one of the things that COSUP can provide, is that level of support. In the words of Mark Lewis, a temporary scaffolding to support a vision of future self until somebody grows into it. I don't know if there are other questions, or Prof, you want to add to that? Or
yeah, I was thinking, if you get to what challenges we have and what we've learned, I think probably the most important thing of COSUP was that we did it. And nobody could take that away. And that changed the whole discourse in the country. it led to people people couldn't discuss that anymore as a theoretical issue. It was there to be looked at with its mistakes, with its whatever. So I think the most important thing we did is that we did it. But now that we did it, it's a matter of how do we take it further, and how do we diversify the COSUP approach and harm reduction, etc. And that is what I want to say, is that we have not been successful to integrate COSUP into the formal health system. We've really made inroads in hospitals. We've got hospitals responding differently to people who are admitted, who are using substances, etc. We've had some places like Eersteris, etc., but we haven't been able to integrate it. So the point now that we are at is to say, how can COSUP as a platform be made available or collaborate with the formal health services to present a more comprehensive response to people who are vulnerable, of which people who use substances is just one of a range of that. So that COSUP becomes a platform and a resource for a more comprehensive approach for people who cannot or do not access the health system, and that's what we're thinking at the moment on how to go about that. Thanks.
So from my perspective, right from the beginning, I knew it would be challenging to bring these services into a very formal health setting, and I've seen that all over the world as well. The more you professionalize, and I'm not saying the opposite of professionalize is unprofessional, it's just a different approach. I'm talking the more you make something very clinical, the less attractive it becomes to a lot of people, and you need to be attracting people who want to be there, and it's about the relationship they form with the services. And it's typically speaking, the hospitals that I've worked with and the clinics I've worked with, there's been a very punitive and very top-down directive kind of approach, which we know doesn't work with people who use drugs. In fact, it doesn't work with people, full stop, in my opinion. And there's a lot of data to support that. So I agree with you. I think the real way forward is how to broaden the platform that's been created and if we had fully implemented COPC models in South Africa, one would imagine that you could work with those to spread services for people who use drugs as well. I think the other big barrier we have is this concept of abstinence is the only option, which is clearly not true when we look at a lot of the people I've been working with. And so one of the things I often tell people is, and people who use drugs as well, is you don't have to make changes to your life only once you've stopped using drugs. You need to start making changes now. And just because you're using drugs isn't an excuse not to make positive changes or to become a contributing member of your community. And so as we can broaden these services, I think that we will see more buy-in, we'll see greater return on investment, and we will see sustainability through government and in particular local government funding and support. Because if, as everybody says, drug use is the biggest problem in our country, if in communities we can make a difference with that particular population, we are making a difference to the community and things will get a lot better. Of course, I'm of the opinion that drug use is really, how should I say, dependent drug use is a symptom of a broken society, not vice versa. But either way, having the services available in the community with the community involvement, and I haven't touched enough on the fact that peers were heavily involved in the design, implementation, and monitoring of the service, and that is essential because you can't be talking about a population if you're not actively involving them. And that's the other thing that's unique about COSUP, and we've written about that in a couple of journal articles, is the level of involvement of members of the community, of people who use drugs. and they're taken seriously and their input is valued. Yeah. Are there any other questions? I think we're almost out of time, if I'm not mistaken.
Yeah. While you are looking for the questions, I just need to acknowledge the role of the city of Tshwane through many years supporting us against many ways of not doing that. And I see Suki is in the audience, and one of the things we did in the beginning of COSUP was to seriously challenge the police with whatever was done, and Suki unfortunately was the one that was arrested on the first or the second day of her work in COSUP, and the charge was that she had some sterile water in her possession. Thanks again, Suki, and I'm glad that we had better outcomes. Thanks.
Yeah. And some of those battles we haven't quite won yet. Somebody from our team was arrested this morning and is still negotiating their freedom at the moment. They were offered an admission of guilt fine, which they turned down. But yes, we've got to change the criminal justice approach. I'm glad to see Minister Lamola is shifting his position, and certainly the Deputy Minister of Justice has, and the Deputy Minister of Social Development has been quite vocal about decriminalisation of people who use drugs. Yeah, so we're coming up to time now. Dee, I think we're pretty close to closing off at this stage. We hope that there's been some useful conversation here. With the shift towards methamphetamine use, our next session in 2 weeks' time will be about methamphetamine. And that's something that I've had a lot of experience on. I sit on the global panel of methamphetamine experts, or stimulant experts, should I say, and co-authored the UNODC guidelines on harm reduction for stimulants. So I hope to get a colleague of mine onto that as well. All right, Dee.
Thank you so much, guys. Shaun and Prof, thank you. So as Shaun has stated, our next session will be on the 22nd of June. It's called The Up, and we'll be talking about stimulants. So Prof and Shaun, you have an audience of people on the field, on the ground. What last short encouragement can you give them as we close?
From my point of view, I'd just like to say thank you to all the people who are on the ground and who've worked so hard to get this going, Dr. Krokam, Dr. Bura, Prince, I see you there, lots of others, too many to name. But the commitment has been tremendous. I don't think you work in this field without having a passion and a commitment that goes above and beyond the normal. So thanks to everybody. And then for the people on the ground, and everybody else, the thing about people who use drugs, and the reason I use the term people who use drugs, is because you can just put a full stop after the people in most instances, because that's what they are, they're people. And somehow we've been misguided and misled into believing that because they use drugs, you need to approach them as if they weren't people, which is just not true. And I've certainly proved that in my own experiences and in the extensive work that I've done over the years. But thanks for listening. Yeah, Prof, over to you to close off.
Yeah, thank you very much. I think the fact that we've been going so long can give us courage. But I'm saying, let's see where we stand now and look into the future and say, what now? What are the new barriers that we're going to cross, and where can we be in 2 years' time? And I know that everybody who's listening, who's on here, are making a contribution. Let's join hands and keep going, guys. And thank you very much. And Dee, thanks for organizing this. You are great. Thanks.
Thanks. Thank you, everybody.
Thank you, everybody. Enjoy the rest of your day. And please keep posting on the teams, post your questions so that we can have topics that are more relevant to you. Thank you. Bye.
Bye.